you, Nicole. And thank you, everybody, for taking time and joining us this evening. My goal today is to sort of keep the presentation brief, introduce you to atrial fibrillation, which you already probably have self-researched and know a lot about. And then as the Q&A and the comments come through, we can elaborate more on the topic that is of interest to the group. And I would hope that Virginia Hart will continue to sort of explore further beyond the general conversation about atrial fibrillation, about the catheter ablation, the types of ablation, and we can explore these further in the future webinars. Atrial fibrillation is the most common arrhythmia that we encounter. It is the most common arrhythmia for several reasons. One is the diagnostic proficiency has improved. Two is that the aging population and the predisposing factors that increase the prevalence of the disease have also increased.
Dr. Rashid, do you mind sharing your slides?
Okay, let me see. Is everybody able to see the screen?
Yes.
Okay. So moving on to the next screen. As I said, atrial fibrillation is the most common cardiac arrhythmia and is a growing problem. By some estimates, 5 million people with atrial fibrillation have carried the diagnosis in US, and by 2050, up to 12 million Americans may be impacted by this arrhythmia. It has some significant impact on quality of life, and there are, fortunately, several treatment options available now, both from the standpoint of drug therapy and minor surgery, also known as catheter ablation. What are the risk factors for atrial fibrillation? Age-adjusted atrial fibrillation incidence is predicted to grow as a result of increased risk factors, and those include obesity, high blood pressure, diabetes, and presence of cardiovascular disease. How does atrial fibrillation impact health, risks, and cost? It has negative impact on quality of life. It is leading cause of stroke, and it increases your stroke risk by 5 times. It increases the risk of heart failure. Increased risk is almost 3 times what of normal, and it increases healthcare costs substantially. 12 billion is estimated in cost to treat atrial fibrillation in the United States. What is atrial fibrillation and how do we recognize it? On the screen, you see 2 depictions of images of the heart. On your left is what represents the normal electrical pathway. You can see that there is a structure called sinus node where the normal impulse in the heart arises. This impulse then travels via a structure called AV node down to the ventricles, and that's how the normal heartbeat is produced. In atrial fibrillation, the upper chamber are no longer in normal rhythm, as that is replaced by hundreds and thousands of these electrical circuits known as fibrillatory pathways. These pathways then essentially render the upper chambers into an electrical storm where the chambers are no longer able to electrically and mechanically beat. Instead, they are what we call fibrillation. This fibrillation then renders the ability to mechanically reduce the output from the chamber to essentially being something similar to a bag of worms. They fibrillate, but they can no longer mechanically beat. And that is atrial fibrillation. In electrocardiogram, the heart becomes irregular, and depending on how many of these impulses can be conducted through the AV node, which is fortunately this channel between the upper and the lower chambers, which blocks off the heartbeat beyond somewhere between 150 to 200 beats per minute. So the upper limit in most people with normal electrical conduction of the AV node, generally the heartbeat is restricted to somewhere very variable, 130 to 200 beats per minute, but it can go up substantially. And that's where the symptoms come in, depending on how fast the heartbeat is. And if the AV node is diseased or can't conduct that fast, or you're on medication for other reasons, like blood pressure medication, some of them impact the conduction in the AV node, then atrial fibrillation can go unnoticed. Where you don't have limiting symptoms and the mild symptoms like fatigue or some change in effort tolerance is not very noticeable. Atrial fibrillation comes in a couple of different patterns. Paroxysmal means it comes and it goes. Atrial fibrillation starts, but then it self-corrects. The persistent pattern is where you are in atrial fibrillation and the heart is no longer going back to normal rhythm on its own. Instead, either you have to use medications or a term that you may be familiar with called cardioversion, where you come into the hospital, the patches are applied to the body, and then an electrical current is conducted between those pads, and that interrupts the atrial fibrillation, and you go back to normal rhythm. A permanent pattern is where any ability to restore normal rhythm is not successful, and this then represents a form of atrial fibrillation called chronic or permanent atrial fibrillation. There is quite a bit of gray zone here because increasingly the efficacy of the treatment allows us to treat atrial fibrillation even if it has gone on for a few months to a few years. Factors that are associated with or causatively related to atrial fibrillation. One of the most common things, which is not in our control, is age. As we age, the risk of atrial fibrillation increases. We believe the degenerative changes that affect our body also affect our upper chamber, and atrial fibrillation increases in incidence as we age, especially beyond the age of 60. Every 5 years, almost, it increases and couples and quadruples as we become older and older. High blood pressure, another common association with atrial fibrillation. Increasing weight also is commonly associated with atrial fibrillation. Presence of valvular heart disease, that can also increase your risk of atrial fibrillation. Genetic factors, which we continue to explore, but are not well defined yet. And alcohol consumption is very commonly associated with atrial fibrillation. In fact, it would not be unfair to say that you can, quote unquote, drink yourself into atrial fibrillation, as alcohol changes the electrical properties of the upper chamber in a way that it favors atrial fibrillation. Another important thing to note, which can affect a very small subgroup of people, that extensive sports, particularly those that are aerobically intense, like long distance running or long distance cycling, can increase your risk of atrial fibrillation. Symptoms of atrial fibrillation are quite variable. These include shortness of breath, racing heart, fluttering or palpitations, dizziness or lightheadedness, and these vary quite a bit. Sometimes if shortness of breath is very mild, a patient may not recognize that actually it's atrial fibrillation which is doing that. Palpitations are also not always present, but they can come and go. And dizziness or lightheadedness is also quite variable depending on heart rates, blood pressure, use of other medications. And although not listed here, in the initial symptom that a patient recognizes is fatigue. And it is often the case where the other symptoms are mild enough that a patient may sort of just ignore those. And fatigue is something which also occurs as we age. So it's not uncommon where we attribute, oh, I'm just more tired because I'm older. But atrial fibrillation can be a major contributor to symptoms of fatigue. And as I said, sometimes there are no noticeable symptoms at all. And it is not uncommon that we see that patients come to their doctor for a routine visit, or they are having a pre-op visit, or they're getting their colonoscopy, and then suddenly they're told, you're in atrial fibrillation. Why does it matter? AF or atrial fibrillation can put you at risk for other complications. It increases the risk of blood clot. And as we talked about, the irregular heart rhythm renders the capability of the left upper chamber particularly to mechanically empty itself to minimal. And that causes the left atrial appendage, which is an extension of left atrium, and is no longer beating, the clots can form inside this chamber. If a blood clot forms in the left atrial appendage, and it can break from there and travel through the vascular system to the brain, it can cause a stroke. It can go to the other system. It can go to the intestine. It can go to kidney. It can cause infarct. And very rarely, it can also go, a small clot can go into the arteries of the heart and can produce a heart attack. But those are very uncommon. Fortunately, the organs other than the brain are usually able to cope with small clots, but the brain is a organ which doesn't function very well if part of its blood supply is compromised. Atrial fibrillation, if it continues over a long period of time, or in a subset of patients where either the heart rates are too fast or heart is quote unquote very sensitive to this irregular beating, it can weaken the heart muscle, cause something called atrial fibrillation mediated cardiomyopathy, meaning a weakened heart muscle caused by atrial fibrillation, or sometimes a term is used, tachycardia mediated cardiomyopathy. Tachycardia means fast heartbeat, and cardiomyopathy means weakened heart muscle. So in several different ways, atrial fibrillation in susceptible patients can weaken heart muscle and cause heart failure. In majority of the patient, it has significant impact on quality of life. And this is my closing slide, and this would open up the forum for us to go into questions so that we can then explore symptoms, treatment, and other topics of interest. There are medications which are there to control the heart rate or heart rhythm. You will hear the term rate control often in atrial fibrillation. That means that if there is a patient who is older, has several other comorbidities, in whom the heart rate is controlled and they can tolerate the blood thinner, sometimes we can leave them in atrial fibrillation and put them on medication which can control the heart rate but not restore normal rhythm. And in a certain patient, that could be acceptable treatment. if the idea is to restore normal rhythm, then our options are either trying heart rhythm drugs specifically designed to restore normal rhythm, often coupled with cardioversion, or restoration of normal rhythm through a combination of use of medications or combining them with cardioversion. The surgical treatment for atrial fibrillation, which was a mainstay for many years, over a decade ago, is no longer something we use given how advanced the catheter ablation has become. Pacemaker and defibrillators, when they are already in place for one reason or the other, can be used in conjunction with medication. Although pacemaker and defibrillators are never implanted specifically for management of atrial fibrillation because they don't play any direct part in restoring normal rhythm or maintaining it, unless a patient had a need for one of those two devices for other reasons. The mainstay of therapy now, and according to the most recent guidelines, the first line of therapy is catheter ablation, in which we go put patient under general anesthesia, and then we put catheters into the heart, and using either radio frequency, which is heat, cryo, which is freezing, alcohol, which is injection of small amount of alcohols into the targeted part of the atrium, or PFA, or electroporation. You will hear a lot about it because it's a newer technology, recently got approved, and we will be using this method of creating electrical score in the upper chamber to restore normal rhythm as well. As indicated at the bottom of this slide, starting last year, the guidelines, which come from American College of Cardiology and American Heart Association, has now recommended atrial fibrillation ablation in the suitable patients as the first line of therapy to restore and maintain normal rhythm, of course, coupled with all the lifestyle modification that we previously talked about, and specifically, attempts to weight loss if you're overweight, minimizing alcohol intake, and treatment or treating sleep apnea if a diagnosis has been established. So I'll stop there, and now we will go over to questions to see what else we can explore in today's discussion. I will go ahead and stop sharing my slides.
Thank you, Dr. Rashid. Like Dr. Rashid said, we're going to now start answering your questions that were submitted in advance or submitted through the Q&A button down below. So if you still have a question, please feel free to submit it. Once you stop sharing your slides, Dr. Rashid.
I think I paused it, so.
It looks like they're still showing.
Okay, let me see. Okay, there we go.
There you go. Perfect. Okay. So the first question, for someone who has persistent AFib for over 10 years and they wear an iWatch for AFib monitoring, is the data from the iWatch useful in their evaluation, or are there other apps that you suggest they use?
There are several variables which are now available which allow you to monitor your heart rhythm. If you are in atrial fibrillation for several years and you and your clinician has made a decision that the way to treat that would be to adequately control heart rate, I think the value of iWatch may not be that critical anymore because you're in atrial fibrillation and it has been determined that that is effective way to control your arrhythmia or treat. The upside and downsides to iWatch are that if you're going in and out of atrial fibrillation, it's a very useful tool. If you are in atrial fibrillation persistently and decision to leave you in atrial fibrillation has been made, then that data becomes less useful. Actually, it could be more anxiety provoking. Then you're in atrial fibrillation, the iWatch is going to throw out all these numbers, which may not always be accurate. And, if you find it useful, there may be value, but I think from clinical standpoint, it has very limited value to offer at that time. I can't hear you anymore.
Sorry.
Okay.
After a successful ablation procedure, what is the risk of recurrence of AFib or flutter, and when does this typically occur?
So again, it varies considerably depending on nature of your atrial fibrillation. And some of the terms may be a little confusing, but if you have paroxysmal atrial fibrillation, meaning your arrhythmia is self-correcting, and the procedure performed was limited to what we call basic ablation for atrial fibrillation, pulmonary vein isolation, in which the operator goes in, confirms that the veins are electrically active, and then using one of the modalities we discussed, electrically isolate the veins, and rest of your atrium was healthy, and you don't have a valvular heart disease. I think the data is that, and if we were to assess where you would be in 5 years from now, there's an 8 out of 10 chance that you will be in normal rhythm. If, on the other hand, the atrial fibrillation felt persistent, the chambers were dilated, and the ablation included more than pulmonary vein isolation, then your risk of recurrence is high. If the ablation was extensive and you did not go back into atrial fibrillation, you may end up experiencing things called flutter-like circuits, in which the arrhythmia is no longer truly irregular as atrial fibrillation, but it's organized and regular. Some of it is maybe because the electrical scar in the upper chamber exists, and some of that may be because the extensive ablation rendered some areas electrically quiet, but others electrically active and allowed some circuits to form. But with the modern technology and the mapping tools that we have, these channels can be effectively eliminated through follow-up procedures.
Okay, thank you. Do you mind sharing some of the risks of ablation?
So catheter ablation is considered a minor surgery and a low risk procedure. The catastrophic risks that we sort of like to avoid, of course, are any damage to the heart tissue, cardiac perforation, which can cause tamponade, phrenic nerve palsy, which is more likely with cryo, or the dreaded complication of esophageal fistula. But these complications, a complication like esophageal fistula occurs by some data in 1 out of 20 to 50,000 patients. So most operators are not going to see it, but we are all very sensitive to it and take all our measures, whether it's monitoring the temperature in the esophagus during the procedure, whether it's avoiding extensive ablation on the posterior wall. And then there are the anesthesia risks. But cumulatively, these risks in the hand of a skillful operator should be less than 1 to 1.5%.
Thank you. If you have PVCs, will this become atrial fibrillation?
PVCs and atrial fibrillation are not related at all. PVCs are premature beats coming from the lower chamber. Atrial fibrillation is a very different rhythm coming from the upper chamber.
Can AFib start as paroxysmal and progress into more frequent episodes?
Correct. It is not uncommon that if left untreated, atrial fibrillation can progress from a paroxysmal to persistent pattern. The definition for persistent currently is that if you are in atrial fibrillation and it doesn't self-correct and lasts more than 7 days, then you are in a persistent pattern. Some will argue that actually shorter, 28, 48, 24 to 48 hours to 72 hours are also now beginning to sort of progress your atrial fibrillation from paroxysmal to persistent pattern. That's why there is some data that suggests that early treatment of paroxysmal atrial fibrillation, whether it's done with catheter ablation or drug therapy, actually prevents you from progressing into more persistent form of atrial fibrillation.
Is catheter ablation recommended for someone in their 70s?
Catheter ablation can be safely performed anywhere from 18 years to, in my practice, my oldest patient was 91. So it all depends on whether or not you are otherwise healthy, whether or not the atrial fibrillation, if successfully eliminated, would actually improve your quality of life. So age is just but one variable that we consider in deciding and recommending whether the atrial fibrillation ablation should be pursued or not.
How do you decide which type of ablation to perform?
If the question is that whether or not using radio frequency or cryo or one of these other tools, then it's really, most of it is institutional memory. It depends on what an operator is more comfortable with. Cryo and thermal or radio frequency ablation were compared head to head. And even though there were some nuances, the outcomes and complications were very, very similar at the end of 1 year. It was a hot and cold trial conducted a few years ago. So I think the goal of the procedure in this subset of population was to render pulmonary veins isolated. And if they are rendered isolated with either cryo or RF, and now PFA, the outcomes are expected to be similar. In my practice, I used all these tools, and at Inova, we have all those tools available and to us.
What role, if any, does caffeine play in AFib or flutter?
So generally speaking, most studies have shown that mild to moderate amount of caffeine for most people should not be responsible for triggering atrial fibrillation. However, if you find yourself to be sensitive to a coffee or caffeine, or if you are drinking 2 pots of coffee a day, that can certainly render you at a higher risk of having atrial arrhythmias and palpitations. And some people can actually be quite sensitive to very small amounts. But most people, and I would say, if I have a patient who enjoys their 1 to 2 cups of coffee a day, I strongly encourage them to continue with that. There's the whole idea of effectively treating your atrial fibrillation is that you can enjoy the normal things without feeling limited. So sort of that's the take on caffeine.
After an AFib ablation, can patients stop taking blood thinners?
A good question. This often comes up. The question of blood thinners is based on a CHADS-VASc score. This is a criteria we use, which includes your age, presence of other risk factors, which is high blood pressure, diabetes mellitus, whether or not you had prior TIA or stroke, and whether or not you have vascular disease. In women, often gender is included, although there's increasing data that maybe gender is not a risk factor. If your CHADS-VASc score is 2 or higher, the recommendation is often to stay with blood thinners regardless of perceived outcome of ablation, because atrial fibrillation can come back and sometimes can go unnoticed. If your CHADS-VASc score is 2 or lower, or 1 or lower, I should say, then after an effective ablation, you should be able to come off blood thinner in consultation with your electrophysiologist. Now, there was a trial, and some of some in our audience maybe may have looked it up. It's called React AF, and in which a strategy was used that you monitor yourself with Apple Watch or a device similar to it, and you restart your oral anticoagulation or blood thinner if you perceive yourself to be in atrial fibrillation. Again, these are the discussions to be had with your treating cardiologist or electrophysiologist as to how sort of risk averse you may be on taking off some of these more sort of outside the guideline approaches to your anticoagulation.
Can AFib return after an ablation?
As we discussed, depending on the substrates, depending on the very reason that it started in the first place, and if your sleep apnea that it could be treated, the triggers for atrial fibrillation were eliminated, and you had limited ablation with the evidence of otherwise healthy electrical voltage in the heart or electrical system of the heart, then your risk of recurrence is lower. If, on the other hand, those risks were present and the lifestyle measures were not adequately addressed, then your risk of recurrence of atrial fibrillation remains high. Because as I presented at the beginning, it's an arrhythmia of aging. As we age, the risk increases. So unless you found a way not to age, your risk would increase.
Is there can you describe what can make AFib come back after a successful ablation?
What makes it come back?
Yeah,
I mean, I think the continuous chamber dilation and if you develop heart disease, if you had a heart attack, or if you develop valvular heart disease, that can increase the risk. And if your sleep apnea gets untreated, or if you end up gaining weight and developing sleep apnea, I've been at it for 20 plus years, and I have seen patients who have gone. I actually recently saw a patient who came back to me and he told me I ablated him in 2006. And he recently developed palpitation. Fortunately, it didn't turn out to be atrial fibrillation, but he had some other arrhythmia. But he went almost, I would say, 16 and a half years without any symptoms at all. But after 16 and a half years, he noted some symptoms. So it can go, I guess, as long as 2 decades and still come back. However, I would say the caveat here is that the modern technology and the treatment is effective. And I think we are offering our patient lifestyle modification. People are more sensitive to living healthy, eating well, sleeping well. So hopefully, if you had an effective ablation and you are observing those measures in your life, your risk would be lower.
thank you. Can you describe the correlation between sleep apnea and AFib?
Sleep apnea is often associated with other comorbidities, meaning that yes, you can have sleep apnea without being excessively overweight, but it is often something which accompanies being overweight. The two factors together can increase your risk of atrial fibrillation substantially. Specifically with obstructive sleep apnea, let's consider somebody who is not actually overweight. It can produce hypoxia, meaning that as you sleep, you stop breathing, the oxygen levels drop, and those then trigger a heart autonomic nervous system to produce either bradycardia, meaning slow heartbeat, or the hypoxia in turn alters the electrical properties of the upper chamber to produce atrial fibrillation.
Is an ICD implant permanent, and can the heart improve to the point where the implant is no longer needed?
So atrial fibrillation has, just to clarify, has nothing to do with ICD implant. We don't implant ICDs for the treatment of atrial fibrillation. The reason a patient receives ICD is weakened heart muscle. If that weakened heart muscle was due to a cardiomyopathy, which is ischemic, or due to previous heart attacks, then it's unlikely that the heart muscle function is going to improve to the point. However, there are scenarios in which the heart muscle function has improved to the point where what made you a candidate for defibrillators in the first place is no longer there. Then you have to consider risks of the benefit of what to do with this device and consider alternatives in consultation with your electrophysiologist to see whether you need pacemaker component or whether the device can be abandoned, because taking out these leads after several years is a very high risk procedure in its own.
Does AFib run in families?
It can, particularly if family members under the age of 60 are afflicted with atrial fibrillation and there are sort of a first cousin, brother, sister, siblings, where there are several members have it. However, the genetics have not panned out where you can predictably say this sort of a genetic, more sort of disposition can increase your risk of atrial fibrillation in a determined way. So there's currently no specific genetic testing available for atrial fibrillation, unlike some of the other cardiac disorders where it is well, quote unquote, mapped out.
For someone with permanent AFib, how effective is the ablation procedure?
So the permanent word, as I said, depends. If you have been in atrial fibrillation for more than 5 years, left atrium is dilated, no attempts were ever made to restore normal rhythm, the likelihood that normal rhythm can be restored is very low. And if there is no active symptoms that can be attributed to your atrial fibrillation, it may not be worth the risk. However, if your atrial fibrillation was paroxysmal for many years, it was then determined to be persistent, but the true sort of timeline is not clear, then, in your consultation with your cardiologist or electrophysiologist, you can consider going on to a medication, then attempts at restoration of normal rhythm. And then if the normal rhythm could be restored, there might be value to considering catheter ablation.
Does AFib have any impact on ejection fraction?
As we talked about previously in one of my slides, I mentioned that a subset of patients, either due to atrial fibrillation or due to rapid heart rate in atrial fibrillation, can be susceptible to heart failure or cardiomyopathy.
Can the ablation procedure be performed at the same time as the LAA procedure?
Not at the moment, because these two procedures currently are not approved to be performed simultaneously. If a patient is considering left atrial appendage occlusion device like Watchman, the recommendation would be, from my standpoint, to pursue catheter ablation for atrial fibrillation first. And once the atrial fibrillation component has been addressed, then consider the value of Watchman.
What can you do if you are experiencing extreme stressors daily and palpitations after an ablation?
So there are a couple of things here. One is that you're experiencing palpitations after catheter ablation for some arrhythmia. If it's atrial fibrillation, then the first thing you need to discuss with your physician is that, am I truly having atrial fibrillation? They might apply a monitor or use some other technique to figure that out. Once that has been determined, then the treatment would be whether or not your atrial fibrillation is creating anxiety, or anxiety and the stress is contributing to your arrhythmia. And uh, depending on what comes first, then the treatment is appropriately tendered to target that issue. I would say, though, that stress management is an important component of management of any arrhythmia. So addressing these stress and whether that is a organic issue that is in your life that needs to be addressed, or whether you need to adopt better relaxation techniques, whether it's yoga or many other things, are an important component of sort of treatment of a broader complex which can produce arrhythmias, cardiomyopathies, other issues, including atrial fibrillation.
For someone taking flecainide, I think I said that right.
Yes.
Should they get an ablation instead of staying on the medication?
It really depends on your choice. If you're happy with the medication, it's working, and you don't have any problem taking it, that's fine. But if you would rather not take a medication, or the medication is poorly tolerated, or um, you know, then certainly ablation is a very reasonable option. And as I mentioned earlier, according to the guidelines, it is a first-line treatment. So you don't even have to go on to flecainide unless you choose to. You could choose to ablation as first line. I'm not saying that's the right thing for every patient, but I would say that if the consensus is that catheter ablation is a very reasonable first-line strategy, then we do believe that uh, medication with all its side effects and commitment that's required on part of patient, the alternative low-risk procedure provides at least equivalent relief from your arrhythmia.
What is the recovery time for an ablation?
A standard ablation with most operators should take about 1 to 2 hours to do. Then you're in the bed for about 4 hours, and you get up and move around. At our facilities with Inova, we discharge most patients home that day with the instructions to kind of go home, take it easy that night. Don't rearrange your closet that night. Just stay in bed. Starting next morning, you can ambulate. You can do everything except the heavy lifting exercise of swimming, which we discourage for about a period of 5 to 7 days. I would say most patients are able to return to their full level of activity after about a week.
What are your thoughts regarding the use of CardioMobile and similar devices for understanding heart arrhythmias? I know you addressed the iWatch earlier, but
Yeah, I think these are similar. These modules are available as Cardia with the phone, but they have been incorporated into the watch as as what allows you to record your EKGs. I think if a patient is comfortable with, these have tremendous value because you can record your rhythm tracings, you can bring them to discussion with your physician, then the physician can treat you with either medications or ablation. And following that, then depending on if there was any recurrence, there is an objective way to address what that recurrence would be. So I think there is increasing value to these technologies.
how common is pericardial effusion following an ablation?
Very uncommon. I would say that falls within the risk of 1 to 2%.
Are you able to identify the lifespan of someone after an ablation given expected recurrences?
So most data says that atrial fibrillation in men does not impact your life expectancy. So again, unless of course you have heart failure or stroke, but purely the arrhythmia itself, if treated effectively, is not going to add years to your life or take away years. So the idea primarily is that it improves your quality of life, allowing you to enjoy your full expected lifespan with fewer drugs and fewer symptoms.
What would be the next steps for someone who's been diagnosed with heart failure, treated with medication, and had more than one cardioversion?
I think then you have to discuss what the role of antiarrhythmic drugs or drugs which are specifically designed for restoring normal rhythm and catheter ablation. There's a lot of data saying that catheter ablation is a very effective tool in patients who have heart failure and atrial fibrillation.
Are women more likely to have AFib than men?
I think overall demographics suggest similar occurrence rates.
Can you describe how an ablation is performed?
So a catheter ablation is performed in a hospital, most places under general anesthesia. Let's say you're scheduled for your procedure in the morning. You'll come a couple of hours in advance of the procedure. You will meet with your physician unless you already met with them and your anesthesiologist. Then you're taken to a room called electrophysiology lab. In that room, you will have a lot of patches put on your body, which include patches which allows us to map your heart rhythm and record the electrocardiogram. And then you're put under anesthesia. We make tiny punctures in your groin. Now, again, there's some confusion often that some heart procedure performed from the wrist. Catheter ablation is not performed from the wrist. It does not involve arteries. It involves veins. And the veins are the same veins that are used when a phlebotomist uses them to draw blood, or the IVs are put into the peripheral veins. So we use larger veins in the groin that allow us direct access into the heart. The catheters are then advanced or kind of snaked up into the heart. Often several catheters are. One catheter that does allow us to sort of take control of your heart rhythm. And then the second catheter, which is echo catheter, meaning that it makes images of inside of your heart and allows us to minimize radiation exposure. The third catheter, which includes deflectable sheets, and the catheter which actually do the work. We go into the right atrium, we put you on a blood thinner, we use a special needle to cross or puncture the septum, which is between the right and the left atrium. Then we advance the catheter into the left upper chamber, then using three-dimensional electroanatomical mapping. A word salad here, but basically the catheter allows us to collect the electrical voltage inside the heart and then generate an image of the electrical health of the heart, determine where these electrical connections are, and then using radio frequency or cryo, we create lines of electrical block around the veins to quote unquote isolate them. Once they're electrically isolated, we wait for a short period of time, then we reassess. If they are electrically isolated, we have achieved the goal of our procedure, which is to perform pulmonary vein isolation. This is kind of describing an elephant. It is, once you see it, it's a much better description. And maybe we can do one presentation where we can do the imagery of a catheter ablation procedure, because if we include everything in one topic, it just gets too long.
Thank you. We have time for maybe one or two more questions. Does anemia increase your episodes of AFib?
Not directly. However, anemia often increases your heart rate, and because your heart has to pump faster to keep up with the fewer blood cells available, but it's not a direct reason for atrial fibrillation.
Can you describe asymptomatic AFib a little bit further?
So as we talked about earlier, the common symptoms of atrial fibrillation are shortness of breath, palpitations, dizziness or lightheadedness, and fatigue. If you don't have any of them, and you're convinced that none of that apply to you, then we will say you are asymptomatic.
Can you discuss any correlation between AFib and an enlarged heart?
So atrial fibrillation is often associated with enlarged left atrium. Now, that is not considered quote unquote enlarged heart. Enlarged heart is considered when your ventricles or primary chambers of the heart are enlarged. That only happens when atrial fibrillation is associated with heart failure, or atrial fibrillation occurs in people with heart failure or cardiomyopathy, where the heart's already enlarged and atrial fibrillation was superimposed on that enlarged heart.
For someone who went from 293 pounds to 261 pounds, will atrial fibrillation ever go to normal with more weight loss?
First of all, congratulations, because you have made tremendous progress in right direction. But in order for you to truly reap the benefit, you will need to continue this journey of weight loss. As your body mass index, and again, I know there are problems with that number, particularly if you're, sort of a workout guy who has a lot of muscle weight, the number may not be accurate. But somewhere between 25 and 28 BMI may be the number where if you get to that number and your atrial fibrillation still continues, then that indicates that in addition to weight, there are other triggers which are potentially not responsive to just weight loss. But I would say I have seen tremendous improvement in arrhythmia burden in patients with weight loss.
Thank you. I think we have time for one more question. Let me see. Can you discuss any correlation between AFib and an enlarged heart?
I think we just addressed.
You did that one?
Yes.
Okay. How do you typically handle the atrial appendage to prevent clots forming after an ablation?
The clot formation in a left atrial appendage is independent of ablation. The clot forms in the chamber because the patient is in atrial fibrillation. In most people, with rare exceptions, the left atrial appendage is not part of our ablation strategy. Ablation is limited to pulmonary veins which are in the back of the atrium. Your left atrial appendage should be at lower risk of thrombus formation, technically speaking, if it's beating normally and no longer in fibrillation. During the procedure, if you were to say, okay, I'm going to be on a blood thinner, but then I'm going to come off, or maybe I'm skip a day or two of medication, although we no longer do that. Am I going to be at increased risk of blood clot formation during the procedure? We put everybody on a blood thinner throughout the procedure. You're fully anticoagulated. So your risk of stroke is negligible to zero during the procedure because you're anticoagulated.
Well, thank you. I think we're all out of time this evening. So I want to thank our speaker, Dr. Rashid, very much for a very informative talk and conversation about atrial fibrillation. We really learned a lot.